So let me begin by introducing our speaker, Dr. Ronald M. Summers, who he received his bachelor's degree in physics, actually, from the University of Pennsylvania. And he also got his MD and PhD degrees at the University of Pennsylvania. His PhD was in anatomy and cell biology. He completed a medical internship at Penn Presbyterian and then did a radiology residency at the University of Michigan, followed by an MRI fellowship at Duke University. Dr. Summers is currently a tenured senior investigator and practicing staff radiologist. He's an abdominal radiologist, and he's in the Radiology and Imaging Sciences Department at the NIH Clinical Center in Bethesda, Maryland. His lab is very well known for developing software for virtual colonoscopy, for computer-aided detection algorithms, for multi-organ atlases, and for the development of large radiologic imaging databases, many of which he shared publicly with the research community. He's been a pioneer in the application of deep learning to problems in medical imaging, including models for detection, classification, segmentation, as well as natural language processing. He's co-authored over 500 journal, review, and conference proceeding articles, and he's a co-inventor on 14 patents. With his research that really spans clinical abdominal imaging, large radiology imaging databases, and artificial intelligence. He's a member of the editorial boards for the Journal of Medical Imaging, Radiology Artificial Intelligence, Academic Radiology, and a past editorial member for Radiology. He was a co-chair for the 2018 and 2019 SPIE Medical Imaging conferences. That's the Society for Photo-Optical Instrumentation Engineers, and program co-chair for the IEEE ISBI, the International Symposium on Biomedical Imaging. Dr. Summers has been honored as a fellow of the Society of Abdominal Radiologists and of the American Institute for Medical and Biological Engineering. He's received the President's Early Career Award for Scientists and Engineers, the NIH Directors Award, and the NIH Clinical Center Directors Award. We are delighted to have Dr. Summers here today. He's going to talk to us about challenges and opportunities in artificial intelligence in abdominal radiology. So Dr. Summers, please.
Great, thanks so much, Kathy, for that wonderful introduction and for inviting me today to speak. Let's see if I can share my screen properly. Hopefully you can see it. All right, great. So I'll be talking today about challenges and opportunities for AI in abdominal radiology. And these are my disclosures. And I'm going to be describing a variety of different research projects that have been conducted at my lab at the NIH Clinical Center. This aerial picture of the NIH Clinical Center shows the campus, the NIH campus just outside of Washington, D.C. And for those of you who aren't familiar with the Clinical Center, it's the world's largest hospital devoted entirely to clinical research. The Clinical Center are the large buildings in the foreground of this image, and then the many other buildings in the background are some of the research labs on the intramural campus of NIH. So my focus today is on AI for abdominal radiology. And for those of you who perhaps aren't familiar with the different subspecialties of radiology, abdominal radiology is a clinically highly important area with its own society, the Society of Abdominal Radiology. And this society in particular has been growing over the years because there's just so much interest in abdominal disease and the applications of radiology for diagnosing abdominal disease. There are numerous organs, some of which I'll be discussing in this presentation, and there are numerous different types of lesions, very important ones, including cancer, inflammatory conditions, infections, traumatic conditions, and so forth, which makes it a very interesting area to practice in clinically. This histogram shows the number of peer-reviewed papers published in the field and indexed in PubMed over the last decade or so. The orange bars show the number of papers for AI in radiology in general. And you'll notice the exponential growth starting in about 2017 as deep learning started having its impact in radiology AI. Now, if you look closely, you'll see these little tiny blue bars, and those blue bars are the number of papers on abdominal radiology AI. You can see they're a tiny fraction of the total. As you might expect, over the last 2 years, some of these papers have to do with COVID, and there's been just a flood of COVID papers, and I'll talk about that in a little bit more detail later in the talk. But most of these papers are in other parts of the body, including the lungs, the brain, the heart, but just a tiny minority on the abdomen, which makes it a great area to focus on, particularly if you're trying to do cutting edge original research. Prior to the deep learning era, my group was using traditional image processing techniques for a variety of different AI applications, including detection of precancerous polyps on CT colonography, identification of the bones in the spine for as a coordinate system and for precise localization of abnormalities, bone mineral densitometry for opportunistic screening of osteoporosis, the automated identification of epidural masses. These are cancerous deposits within the spinal canal, which can lead to paralysis or loss of bowel and bladder function, and are frequently one of the first manifestations of metastatic disease, for example, in this patient with breast cancer. In addition to the colon, we've been interested in small bowel imaging. The blue colored structure on this coronal 3D reformatted image is the small bowel, which was automatically segmented, and the yellow are the mesenteric vasculature, which were used to identify the bowel. This image shows automated segmentation of liver, spleen, kidneys, adrenal glands, and aorta. This is a kidney with multiple tumors in a patient with a hereditary kidney cancer called von Hippel-Lindau syndrome. And this is a close-up view of a CT of the abdomen showing an abdominal lymph node. Lymph nodes throughout the body are of great interest in cancer diagnosis and treatment because they're one of the abnormalities that are measured to determine whether a patient is responding to therapy. So the next part of this presentation, I'm going to focus on body composition. This is a topic that I'm aware the MGH group has been intimately involved with and has published a very important paper recently in the journal Radiology. And I'd like to just tell you a little bit about our efforts in the same area and how we've tried to use a variety of different AI tools together as a method of predicting things like cardiovascular morbidity and overall survival. So body composition is a clinical technique for assessing the components of the body, including the amount of fat, muscle, bone, and so forth. And the traditional methods for assessing body composition clinically are the simple methods of measuring somebody's weight, measuring someone's waist circumference, determining their body mass index, which is determined by measuring height and weight, or determining lean muscle mass. These are surrogate biomarkers for health and risk of disease and are playing an expanding role in clinical research and practice. Over the last 10 years, I've been working on a large-scale body composition project with my colleague Perry Pickart at the University of Wisconsin-Madison. And this collaboration has been extremely fruitful, leading to 22 clinical papers in peer-reviewed journals. The techniques that we've developed use both traditional image processing and deep learning methods. At the moment, we have 5 tools and counting as we add new tools continually. And over the years, we've been continually improving these tools and adding new ones. So here's a single slide overview of the 5 tools that I'm going to talk about. The upper left shows the abdominal aortic atherosclerotic plaque detector. This is a coronal CT image of the abdomen. You can see the kidneys here and the pelvic bones here. And this is the abdominal aorta, and the white linear things here are the hardened atherosclerotic calcified plaque. The red marks on this image show the automated measurement and segmentation of these plaques. This is a liver analysis system that automatically segments the liver and determines the volume and average CT attenuation. This particular patient has a liver that has a high fat content. We call this hepatic steatosis. These Hounsfield unit measurements are indicative of fat in the liver. This image in the lower left shows a muscle segmentation tool at the L3 level. The muscles that are segmented in this particular tool are all the muscles at this level, including the ones around the spine. Here's the spine. These are the paraspinous muscles, including the psoas muscle, and these are the abdominal wall muscles. The fourth tool is one that assesses bone mineral densitometry. This is generally done at the L1 vertebral level, and we take a measurement within the anterior part of the bone. This is the measurement of this particular bone, and numbers below 100 have been found to be indicative of osteoporosis. And finally, this one here is a visceral and subcutaneous fat tool. This is an axial CT image through the L1 level, which is where we normally make these measurements. And the blue and red areas are the automatically segmented visceral and subcutaneous fat. And you can see these images come from a variety of different publications. So I'd now like to briefly go through these 5 different tools. The first is the bone mineral densitometry tool. The graph on the left shows a comparison between manual and automated assessments of bone mineral densitometry. You can see the relatively good agreement, and here's a close-up showing where these measurements are taken. This particular tool needs to identify the correct spinal level, since the measurements are traditionally done at the L1 level. This is a graphic showing the identification of the individual vertebral bodies. In a moment, I'll explain how that works. Our initial method was to assess the entire marrow space, although our latest work is focusing on the anterior marrow space. And in this study, which was our first project on opportunistic screening, where we're measuring things in the body other than those that are being assessed for the primary reason for the CT scan. We did this particular study on over 400 CT colonography scans in which patients underwent a supine and then a prone CT scan within minutes of one another. We measured the bone mineral and found good agreement with an error of about 10 milligrams per cc of calcium equivalent. This particular method uses traditional image processing techniques, including the watershed algorithm and a directed acyclic graph to identify the spinal canal. It also uses a vertebral body template, vertebral body and posterior elements template. It includes the body, the transverse processes, and the spinous process, and then applies active contours to find the precise margins of these structures. The way the individual vertebral bodies are identified is by tracing a line parallel to the spinal canal on a sagittal image, and then identifying the dips in the CT attenuation profile where the discs are located. And the way the L1 vertebral body is identified is by localizing the different ribs in the lower thoracic spine. And this 3D image on the right shows the identification of the ribs and the different vertebral bodies, with the L1 vertebral body indicated in red. The second tool that I'd like to discuss is the fat analysis or adipose assessment tool. The image on the left shows a patient scanned in 2007 and 2017 This particular patient had a lot of visceral fat shown in blue in this top image, but much less visceral fat in 2017. However, looking at a series of thousands of patients in this paper published in the British Journal of Radiology in 2018, we showed annual changes in visceral fat tending to increase relative to that of subcutaneous fat, particularly in men, whereas women tend to have increases to a greater extent in subcutaneous fat. The way the adiposity assessment tool works is by identifying this contour shown in cyan or light blue in this image here at the upper right and lower right. The technique identifies the boundary between the body wall and the subcutaneous fat, and then identifies the fat using thresholding. Inside the contours, the visceral fat, and outside the contours, the subcutaneous fat. The method has multiple traditional image processing steps, including anisotropic diffusion for noise reduction, fuzzy C-means performed twice, first to separate the body from the background, and then to distinguish the adipose from the non-adipose tissue, and then an active contour model that separates the subcutaneous fat or subcutaneous adipose tissue from the internal body cavity. This technique, automated technique, was compared to two manual observers who made the same measurements. You can see that the comparison between the first and second observers and the AI system was comparable to that of the two observers, on the order of about 1% difference. The third tool is our abdominal aortic plaque tool. This is a close-up axial image of the abdominal aorta. This particular abdominal aorta is heavily calcified, as shown by the white inside this red square. The technique first does a preliminary segmentation of the plaque and then a refinement, leading to a final measurement, a final segmentation, which is then measured using traditional atherosclerotic plaque assessment metrics. The graph on the left shows a population study of 9,000 patients, the same 9,000 patients I mentioned earlier, who had undergone CT colonography screening for colorectal cancer. These patients spanned the ages from less than 40 to over 80 years of age. And you can see how their plaque scores in their abdominal aortas increased quite a bit, particularly starting in the age 50 and accelerating in the 60s and 70s years of age. The three different lines show three different atherosclerotic metrics, which were developed for assessing the coronary arteries in the heart, including the Agatston score, the volume score, and the mass score. The image on the right shows that men tend to have greater amounts of plaque than women in each age group, and this is a well-known phenomenon thought to relate in part to the protective effect of estrogen. The way this particular assessment tool works is that we train a convolutional neural network using just the true class ground truth annotations. However, a number of false positives are detected on other calcifications or calcium-containing structures, including ribs and parts of the spine, and calcifications scattered elsewhere throughout the body. So this technique was refined by collecting the various false positives into pseudo classes, for example, parts of ribs, parts of costochondral cartilage calcifications, and so forth. And then the CNN model was retrained using the true classes and these pseudo classes of false positives. And this was a highly effective technique that led to identification of plaques in these two different examples. Another method that we used to remove false positives, for example, on bone and in soft tissues, was to perform the method twice, once on axial and again on sagittal reformatted images. This particular method initially used a 2D mask RCNN with a ResNet 50 backbone. It was trained on low-dose non-contrast CT scans of 112 patients in which every plaque was manually segmented, and it had a sensitivity of 85% at 10 false positives per patient. We subsequently improved this technique so that it could work not just on non-contrast CT, as in the data I just showed you, but also on contrast-enhanced CT. This example shows the improved method on a non-contrast CT colonography. The plaques are segmented here in green. And these two examples show in the lower row show the same patient scanned both pre-contrast and post-contrast, where the plaques are segmented accurately on both the pre and the post-contrast scan. This improved method that worked on both the pre and the post-contrast images was a modified 3D unit with a dice loss. This was developed by Dan Elton, formerly my group and now in your group. This was trained on low-dose non-contrast CT scans of 112 patients in combination with 23 CT urography scans to distinguish the contrast-filled ureters, which the original system mistook for plaque. It was tested on two different data sets, over 900 CT colonographies and over 1,200 paired non-contrast and contrast-enhanced CTs from renal donors, and had high correlation at 0.95 and high kappa scores for agreement with the manual measurements. The fourth tool is the skeletal muscle tool. This example shows the automated segmentations in a patient on the top row with normal abdominal musculature at the L3 level, and a patient with sarcopenia, or decreased muscle bulk, and myosteatosis, or infiltration of fat into the muscle. And you can see the technique worked well on both the normal muscle and the sarcopenic myosteatotic muscle. These two graphs are similar to those I've shown earlier in that the x-axis are different age categories, and the y-axis on the left are the mean muscle area, which you can see decreases through the lifespan, with density of the muscle decreasing at a greater rate than area, at least in the 50s and 60s. The graphs on the right separate the same data by gender. The men are in blue, women in yellow. You can see men tend to have greater muscle area and CT attenuation compared to women throughout the lifespan. Initially, we thought it was important to identify specific muscle groups like the psoas, the paraspinous, or the total versus the total musculature. And we've since settled on using the entire musculature at the L3 level. We also initially thought it was important to identify specific muscle groups. So Joe Burns, my collaborator at the University of California, Irvine, and a medical student working with him, manually segmented each individual muscle as shown in these images. The initial version of this technique used a 2D unit with 51 training and 51 testing cases evenly divided between men and women. It was a consecutive series followed by exclusion of 10 cases, and used contrast-enhanced CT. The results of that study, which we published in 2019, showed excellent DICE coefficients at all 5 lumbar vertebral levels in both the training and the testing sets, with DICE coefficients exceeding 90%. You can see for just the psoas and just the paraspinous musculature, we tended to get slightly inferior performance, particularly at L1. And this is in part why we settled on using all the musculature. And there was a tendency towards higher DICE coefficients at greater muscle quantity. The fifth and final tool I'll mention is the liver analysis tool. Those of you who are familiar with radiology practice will know that the standard method of assessing whether a liver is enlarged, this is the liver, by the way, on a coronal CT, is to measure the height of the liver. The radiologist will draw a line or determine the top and bottom of the liver, and then measure this height here. And if it's above a certain number, that's considered to be enlarged. But as you can imagine, that technique doesn't work very well because livers are highly variable in shape. And some have advocated using the volume. This is the volume of this particular liver. You can see the complexity of the shape and how the height of the liver measurement would vary quite a bit depending on where you made the measurement. This particular patient had CT scans over the course of 10 years, and you can see how the CT attenuation of this liver is decreasing with time, finally becoming fatty infiltrated or steatotic, even though the body mass index did not change. In fact, changed very little, just by 1 unit. On the left, we can see a comparison between manual and automated segmentations in a large number of livers, over 1,000 of these, actually 9,000, I think, perhaps not 9,000, but between 3 and 9,000. I don't remember the exact number offhand. And you can see excellent correlation. The correlation was 0.92. And then in this confusion matrix, you can see very good categorization into these gross categories of liver steatosis. One of the challenges to developing this liver segmenter was that we wanted to segment thousands of livers on non-contrast CT, but the technique we had initially developed was trained on contrast-enhanced CT. So what we did was we did data augmentation by using generative adversarial networks to convert the contrast-enhanced CTs to synthetic non-contrast CTs, and then we transferred the liver segmentation from the manual assessment to the synthetic non-contrast CT, and then used the synthetic images to train the detector. And this method was developed by Veit Sanford, formerly in my group, now a radiology resident at Stanford University, and published in Scientific Reports in 2019. The technique used a 3D UNet. The particular generative adversarial network was a CycleGAN, and it was trained using public data from the liver data decathlon. The DICE coefficients for the in-distribution contrast-enhanced CTs for the CycleGAN, shown in this blue box and whisker element here, were about 95%, and this dropped to about 88% in the out-of-distribution non-contrast CTs. So where are we going with all these different tools? So at this point, we had 5 tools, each of which had been validated. And now we wanted to see what we could predict using these tools. And one of the first of these predictive papers was on cardiovascular risk and overall survival. And this particular paper was published in Lancet Digital Health last year using these 5 tools. These ROC curves show at the top the traditional clinical tools for assessing cardiovascular risk and survival, the Framingham Risk Score and the body mass index. You can see the body mass index was not predictive at all. It was basically a coin flip for predicting risk and overall survival. Framingham Risk Score did better with an ROC of 0.688, area under the curve. This increased for the automated abdominal aortic calcification measurement to 0.743, and for muscle density, 0.721. But when we combine several of these automated body composition metrics, including the plaque, the muscle density, and the liver density, we got an area of 0.811. This shows an example of a patient whose BMI would not have predicted, and his Framingham Risk Score would not have predicted that he was at very high risk for cardiovascular morbidity and poor survival. At his CT scan, his visceral to subcutaneous fat ratio was in the 99th percentile. His liver density was low in the 97th percentile, and the amount of plaque in his abdominal aorta was in the 97th percentile. 3 years following this CT scan, he had a heart attack, and 12 years later, he underwent a repeat CT that showed his liver was becoming fatty, his abdominal aorta was developing even more dramatic amounts of plaque, his muscle was decreasing in volume and quality with increasing fatty infiltration, and his visceral fat was increasing. And within about 7 months after this CT scan, the patient died. Another prediction that we worked on was to predict future major osteoporotic fractures. And this project looked at patients who had follow-up imaging at the University of Wisconsin. Was published in Radiology in 2020. We looked at the bone mineral densitometry. This particular patient had a marrow Hounsfield unit CT attenuation of only 63. You may recall I mentioned values under 100 indicate osteoporosis. This patient's muscle was also fatty infiltrated with an average attenuation of almost -2 Hounsfield units in the fatty range. And 3 months following this CT, the patient developed a displaced left hip fracture. When we went back and looked at this patient's CT scan starting 12 years earlier and leading up to the time before the fracture, we can see that the bone mineral density was decreasing continuously over this period from 135 to 92 to 72 and then to 63. So in principle, this patient could have been detected as being at risk and treated prior to developing this fracture. So now what I'd like to do is switch gears a little bit and talk about some of our efforts in developing large-scale AI radiology projects. I'd like to start with this first project that we worked on back in around 2014 that we published at the Computer Vision and Pattern Recognition Conference in 2015 in the Journal of Machine Learning Research in 2016. What we did was we took a large number of CT and MRI scans. There were 780,000 of them. And of the 780,000, 216,000 had key images. These were images that the radiologists had marked as showing a clinically important finding. What we then did was we extracted from the radiology report the sentence that described that image, because the image was mentioned, the image number and series was mentioned in the sentence. And then we used the sentence from the report as well as the images to train a CNN to label the image. In this case, it correctly determined that there was a mass on the kidney on this abdominal MRI showing a cancer on the kidney here. Another approach we took was to use the RECIST measurements. RECIST stands for Response Evaluation Criteria in Solid Tumors. These are measurements that radiologists make during their routine clinical reads, and these measurements are stored in our PACS archive and could be extracted in order to develop this data set, which we call the deep lesion data set, and we've made it publicly available at the URL shown here. This particular data set includes lesions throughout the body, including not just the abdomen, but the lungs, neck, and even brain. But some examples in the abdomen include lymph nodes, kidney lesions, liver lesions, pelvic lesions, and bone lesions. There are 32,000 lesions, each with annotations. These are from over 10,000 CT scans from over 4,000 unique patients. This is an example of one of these RECIST measurements on a left adrenal lesion. You can see the measurements are bidirectional. That's the RECIST method. This data set was first used by our group to develop a universal lesion detector. This work was led by Ke Yan, a former postdoc in my group. And the universal lesion detector identifies all types of lesions throughout the body, not just a single type. So for example, this AI that he developed can find liver lesions, lymph nodes, splenic lesions, and lesions in other parts of the body. I'll briefly mention two other data sets we've made available that are pertinent for abdominal AI system development. These include the lymph node CT data set with 176 CT scans with manual segmentations of all the lymph nodes and some other metadata. And you can get this data set at the Cancer Imaging Archive. We're working presently on developing a similar data set for MRI. These show some different lymph nodes in the abdomen on MRI scans presented in work led by Tejas Mathai, currently in my group. He presented this just within the last couple of weeks at the MICI MLMI workshop. Another area we've been working on is semi-automatic RECIST measurements. This is a lesion in the upper abdomen that's automatically measured using the RECIST technique by an AI system and compared to manual measurements from 3 different radiologists. The technique uses a spatial transformer network for lesion region normalization and a stacked hourglass network shown here to improve the precision of the RECIST estimation. And this method had error less than that of 2 human observers. These images show a comprehensive spine oncology analysis system that was developed in a series of projects led by Jack Yao, a former staff scientist in the clinical image processing service that I supervised. This oncology analysis suite of AI tools can identify lytic, sclerotic, and mixed lytic and sclerotic spine lesions as shown in these images. And this is the pancreas CT data set with 80 CT scans also found in the Cancer Imaging Archive. This particular data set has been used by investigators around the world to improve performance of different AI systems for the pancreas segmentation. This example here shows manual and automated segmentations. The manual segmentation is in red and the automated in green. The DICE similarity coefficient was 78% for this particular case. Here's a 3D comparison of the manual and automated. And we've been very interested in quality assessment of segmentation accuracy. And in this quality assessment study, we found that the quality of pancreas segmentation depends to a great extent on how much visceral fat abuts the pancreas. This is visceral fat here. This is the pancreas. You can see when the fat is adjacent to the pancreas, there's a nice sharp contour, which is missing when the patient doesn't have much fat. And consequently, the automated contour, in this case shown in red, is of poor quality. I showed earlier that I've had a longstanding interest in bowel analysis. I'm not just interested in the large bowel, but also the small bowel. A 22-foot long on average structure that can have extensive variability in shape and location. This is work led by Sungyeon Shin, a current postdoc in my group, that uses principles of persistent homology, a topological loss function, and a cylindrical constraint to segment the small bowel. And in an improvement that he presented within the last couple of weeks at the MICI meeting, he showed a method of disentangling intensity and non-intensity features using a 2-stream auto-encoding architecture that led to improved accuracy as shown in these images on the far right. For colonic analysis, we've looked at trying to understand why patients with greater amounts of visceral fat have a much greater risk of developing colorectal cancer. And in this project, we identified parts of the wall of the colon that were surrounded by visceral fat, and shown in yellow here, and parts that were not surrounded by visceral fat shown in purple. And we found that polyps tended to be in parts of the colon wall that were adjacent to visceral fat compared to areas that weren't. There was just a slight preponderance. And we hypothesized that this might be part of the story about why polyps tend to form to a greater extent in patients with greater amounts of visceral fat. A challenge has been connecting AI metrics determined from radiology studies with findings from surgical and less invasive interventional techniques like endoscopy. In this project led by Jimin Liu and published in TBME in 2012, she showed how to find a polyp located at a specific location on a CT colonography on the optical colonoscopy. And the reason this is a challenging project is because a colonoscope deforms the colon as it's inserted into the colon, so that any measurements that were made on the CT can't be directly used with the colonoscope. And the method that she used is to simulate the deformation of the colon by the colonoscope and then to map the location of the polyp from the CT to the optical colonoscopy. And you can see that the accuracy of this technique was to within 10 centimeters, which turns out to be the distance between localization markers on the colonoscope itself. So to conclude, since time is running short, I'll just mention some of the challenges and questions that my group is interested in and working on. These include interpretability and explainability, brittleness due to domain shift problems, and ethics and trustworthy AI. And in the area of domain shift, I believe that using things like the generation of synthetic non-contrast CT or similar types of synthetic alternative versions of CT, MRI scans, and other types of radiology images will be very useful for data augmentation and to handle problems with disentangling domain shift issues. I mentioned earlier I'd make some comments about lessons learned from the COVID era. Those of you who have been following AI of COVID on radiology know that there have been hundreds, if not thousands, of papers on AI of COVID on radiology, and there's been just tremendous duplication of effort. I'm glad to see that clinically relevant data and endpoints are of greater interest in the latest crop of papers on this topic, and I think that is pertinent to AI of abdominal radiology as well. If you'd like to learn more about some of my thoughts on this topic, I encourage you to check out my recent editorial on radiology. One of the last things I have time to mention is some approaches to using fewer labels, particularly for rare diseases. Some of these approaches are shown on the left, including zero-shot and few-shot learning, transfer, unsupervised, semi-supervised, and federated learning. Zero-shot learning is a particularly exciting area where AI is trained using using images from diseases other than the disease of interest. So you have no training data for the disease of interest. And if you'd like to learn a little bit more about how that works, I'd encourage you to check out Angshuman Paul's papers, a former postdoc in my group, that were published in Medical Image Analysis and TMI earlier this year. This particular work was on chest imaging, but would equally apply in the abdomen. So to conclude, the abdomen is a relatively less studied area, but it's a tremendously important area of the body with many diseases that are of considerable interest to patients and their clinicians. And I do expect practical clinical benefits for AI in abdominal radiology, not just for the opportunistic screening that I mentioned during the body composition part of this study, but also for particular individual diseases. I'd like to acknowledge the contributions of my many colleagues and funding sources, in particular the individuals identified in yellow, Perry Pickart at the University of Wisconsin and Joe Burns at UC Irvine, and my colleagues formerly at NIH, including Jack Yao, Jimin Liu, Veit Sanford, and Dan Elton. To learn more Please don't hesitate to drop me an email. Here's my email address. It's probably one of the shortest email addresses on record. And you can also check out my website and our group GitHub site. So thanks so much for your attention, and I'd be delighted to answer any of your questions.
Well, thank you so much, Dr. Summers. That was quite a body of work, incredible, and very profound images that make me think I need to reduce my fat intake and go for a run right now. Very interesting to see what you can pull out of imaging of the abdomen. And you're right, this has been an area that has really been underserved in many ways in the world of current deep learning. I noticed that you've been doing this for a very long time and started with classical machine learning techniques. Are you still using some of those classical techniques, or have you gone strictly to the deep learning and more of the automated and data-driven methods?
Yeah, we've been transitioning to more deep learning methods, and certainly the new techniques that are in development now in my group are predominantly deep learning methods, but we sometimes find that you still need to be aware of and integrate traditional image processing techniques for certain problems. So for those who are listening and who are studying data science and medical image processing or other types of image processing, there is still value in being aware of the different traditional image processing techniques.
Great, thank you. And folks who have questions, feel free to put them into the Q&A box, and we can provide those for Dr. Summers. A couple of other questions. Well, one, I'm interested in the composition of your lab. I know your lab is large and has been in existence for a number of years. But is it all clinical people, or do you have data scientists who are there? What's the predominant makeup of your research lab?
Right, that's varied over time as the group has grown and shrunk depending on the funding and people coming and going. Right now we have 2 radiologists, myself and Grace Lee, and the remainder of the group are predominantly computer scientists. They consist of staff scientists who have Ph.D.s, postdoctoral fellows who are doing training, and more junior trainees who are just out of college and doing post-baccalaureate fellowships in my group prior to going to graduate school or medical school. So mainly a computer science group. We have had biomedical engineers over time, and we've also had people coming from other backgrounds, including physics and other areas of science who are transitioning to data science careers or machine learning careers.
Such as yourself, who came from physics. Interesting. Yeah, I noticed one thing that you mentioned about examining the failure cases when a deep learning model doesn't work, and then modifying based on what you find in those failure cases. And I think that, something that we found at our institution is working together with a clinical champion has helped us to understand those particular failure cases, and the value of having someone who really understands the clinical activities is very, very important. We have a question from Michael Rosenthal, and both Michael Rosenthal and Florian Fintelman are on the lecture, and Michael is an oncologic radiologist at the Brigham and Dana-Farber, and is studying pancreatic cancer and has done the body composition, and Florian Fintelman is a thoracic radiologist at MGH who looking at body composition for thoracic surgery, and they've done some work that I know you're aware of. But Michael asked, what do you see as the path to bringing these methods into broad clinical use? And he stole my question, but there you go. How do we move these things into the clinical environment? What needs to be done to make this happen outside of the NIH or outside of some of our academic centers?
Right. Thanks for that question. That's been a topic that's been on my mind throughout my entire career. I struggled to transition our CT colonography polyp AI to clinical use. We ultimately did, but it was a long and difficult path until finally it was licensed to a company that went on to developing their own commercial polyp AI system. I think the body composition AI tools are kind of heading down that path towards clinical implementation. We see a lot more interest from many more research groups in the idea of AI for body composition. We're seeing interest by various radiologic societies, including the ACR. We're seeing interest from companies. Dr. Pickart is leading a group that I'm a member of called OSCAR, or the Opportunistic Screening and Radiology Consortium, and we're working with, I think he's got perhaps a dozen different large medical centers interested in collaborating with us on a very large body composition study, multi-institutional international study. So as the evidence starts accumulating, I think there will be a cultural or mental shift in the radiology profession that doing things like body composition analysis is something that should be done routinely. You know, it doesn't require, it's opportunistic. It doesn't require any additional scanning. The data is already there. It's just a question of running an AI algorithm. There's no additional radiation. So, and I think showing that all these predictive models work in different patient populations, and that the domain shift issues are not a big problem, which doesn't seem to be the case, since we've been using these tools on data from different institutions, and they've been highly accurate. So as radiologists become more comfortable with the idea that measuring body composition can be a standard part of their clinical read, I think you'll start to see it being done more. But these cultural and mental shifts take time to happen, in my experience. They don't happen overnight. It requires lots of people talking about the utility of this. It requires clinicians, champions being on board to talk about the utility of these things. And then there's also going to be demand external to radiology from other clinical specialties who find that these techniques are very useful for whatever they're doing. Now, I'm in a research environment, so there's a lot of people interested in research applications of these techniques, but we're starting to see interest from clinicians worldwide for a variety of different applications. I'll just rattle one off the top of my head. There's a lot of interest for liver transplantation in body composition metrics, because the survival and prognosis of liver transplant recipients depends in large measure on whether they're frail or not. And body composition metrics are great for assessing frailty from an imaging perspective. There are, of course, also functional metrics that physicians can do to assess the performance of muscle, for example, like muscle strength testing. But there's a tremendous amount of interest there. I mean, there's even a journal that focuses on sarcopenia. So I think this is probably, body composition in particular is an area that we probably as radiologists perhaps don't appreciate how much interest other medical specialties have in collecting this information.
I mean, it's a great example of being able to take information that's in the images that maybe we're just not using. I mean, we often look to create better and better quality images from a spatial resolution and contrast resolution and so on, but we have a lot of data in there that we're not using, or you're not using as you compile your interpretations and your reports, and you're using it for really predicting health, which is, I think, something that's sort of the next step in what we're seeing. You know, much of the papers that we've seen, particularly in imaging and radiology, has really been around diagnosis, but you're really using a lot of these tools for prediction, which do you think that's the next frontier for these technologies?
Right. Well, once these tools are developed and they're shown to be effective, one really doesn't need to keep focusing just on improving segmentation quality, for example. I think, to me, it makes the most sense to find a relevant clinical application and then to see whether the tool is useful, because radiologists don't routinely segment things in their clinical practice. So, they're generally not that interested in automated segmenters. There are obvious exceptions, but generally segmentation is not that useful, because radiology as a field has done well, just fine, thank you, without having routine automated segmentation or manual segmentation for that matter. But I think particularly explainable predictions, like in this particular scenario, these are 5 explainable AI systems. If I give you an automated measure of liver CT attenuation, you can quickly check that and know that it's correct. So that's explainable. The predictions tend not to be explainable, but they're built using explainable metrics. And I think the clinical utility of predictions is going to have to follow the same path as the body composition, for example. It's going to have to be proven by many different research groups using many different patient populations in ways that shows that it's generalizable to and useful predictions that perhaps exceed those of current clinical measures before clinicians will become comfortable using them.
Interesting. And you mentioned making sure that the tools work on many different populations, and you've helped with that, and we thank you for releasing a lot of your data for researchers to use in these technologies, and that's one way to help move the field forward as well. I don't know, hopefully we can encourage more people to share data, but I think that's been a wonderful activity. We're out of time. I want to be respectful of your time, but Dr. Summers, thank you so much. That was fantastic. We loved having you as our guest today, and we'll have to treat you when you come back to Boston.
Thanks so much, Kathy, and thank you all for attending.
Great. Thank you, Ron. Thank you so much.